Good afternoon. Sorry for this attack because I have to back to the what. The word COVID appeared in the lexicon of amongst the medical professionals and the world at large, probably in just last couple of years, with cataclysmic consequences. But I think what has emerged out of this entire process or a journey has been the resilience of the human spirit. It actually arose like a phoenix from the ashes. And it is, a little part of this journey is what we want to present today, because it is this resilience. The resilience actually defines as never give up is one. And the second is the ability to work as a team, put all the brains to be able to find solutions to something which seems like impossible, something which is there as dead and gone. And that's what I thought, that this was a case in focusing on this aspect, a very small thing. But then I thought this showcases that resilience of people. So without taking much of a time, I will request my colleague, Dr. Anu Gupta, from faculty from Department of Neurology, to take on. Anu, please.
Thank you, ma'am. So today we are going to present a very interesting case, which is special for two reasons. Number one, it's a deadly disease, rare, yet treatable, so important to be aware of. And number two, as ma'am said, it brought up a lot of team effort, a lot of persistence, and we had a success story in the end. So to start with the case, I invite Dr. Govinda, Senior Resident, Department of Neurology. He will be presenting the clinical part.
Good afternoon, respected teachers and my dear colleagues. So today I am presenting an interesting case from the Department of Neurology with a title Tale of COVID and the Brain Eater. So I am presenting in the following subheadings: clinical presentation, differentials, relevant investigations, further clinical course, treatment, discussion, followed by conclusion with a take-home message. So my patient, 32 years old gentleman, resident of Faridabad, lawyer by profession, without any prior comorbidities, presented with chief complaints of progressive weakness of right upper and lower limb 1 month duration, right-sided facial weakness with slurring of the speech 3 weeks, and fever, headache, vomiting 2 weeks, and altered sensorium 2 weeks. He was in 2 private hospitals in the month of January. Then after 1 month into his illness, he presented to the AIIMS in February last year. So patient is apparently all right till November 2020, during which he was affected with COVID pneumonia, which was treated along with antimicrobial along with steroids, which tapered over the next 2 weeks. He completely recovered and asymptomatic in the month of December. During that time, he was newly diagnosed as diabetes mellitus. So on 2nd January last year, so while he was driving his car, he met with a minor accident that as he could not able to judge the exact distance from the neighboring vehicle. But this did not lead to any injuries and hospitalization. While he was taking rest for the same, 3 days after that, on 5th January, so while he was writing, he noticed that right hand weakness. So this was slowly progressed over the next 3 days, involving the whole right upper limb weakness along with the right foot weakness. He was dragging his right foot while walking, along with right facial weakness that leads to slurring of the speech. With these complaints, on 8th January, so last year, he was admitted in a private hospital where the imaging has been done, which shows bilateral lesions, which were multiple nodular and ring enhancing lesions. The larger size on the left side with lipid lactate peak in the spectroscopy. CSF was done, which was not much contributory because it was so clear, and 4 cells all are lymphocytes. All the stains, cultures, and related to bacterial, fungal, tubercular, all workup was negative. And he, with a radiological suspicion, he was started on 5 drugs anti-tubercular treatment along with dexamethasone. This was imaging just to show that these are the lesions with significant edema that were extended to both sides. So with enhancement. So this will be discussed in detail in further neuroradiology department. So in the same hospital, his clinical conditions in the 3rd week of his illness worsened in the form that right-sided weakness was worsened, and he's also developed a new left-sided weakness also. Along with, at that time, he was running high-grade fever with raised ICP symptoms in the form of headache, nausea, vomiting. And the image was showed increasing the size of the lesions as well as the surrounding edema. With a suspicion of ADAM, so he was treated with pulse steroids MPS for 5 days, along with followed by IVIG 5 days course. As there is no improvement, he was shifted to another bigger private hospital on 21st January. 3 days following that, his sensorium GCS Glasgow Coma Scale dropped to E2 V1 M5 and increasing the size of the lesions in the imaging with significant perilesional edema along with mass effect and midline shift, because of which he was intubated and decompressive hemicraniectomy was done and brain biopsy was taken at that time. In the post-operative period, he was kept on cefotaxime and vancomycin. So ATT and steroids which were started already continued, and acyclovir was also added to the treatment. So with this treatment, so on this treatment, his sensorium was also again further dropped to E1 VT M4, and he was running high grade fever. So because of which his antibiotics were upgraded and antifungals were also added. As there is progressive worsening, he was referred to the AIIMS hospital on 2nd February 2021. In the AIIMS emergency, he was febrile with high-grade fever, pallor present with no lymphadenopathy, tachycardia is present, normal blood pressure, RR is 20 per minute on SIMB with 40% FiO2, respiratory system shows bilateral crepitations more on the right side. So on the neurological examination, GCS E1 VT M4, bilateral pupils are equally reacting and equal in size. So on painful stimulus, there is positive movements, more positive movements on the right side. Bilateral 2+ deep tendon reflexes and bilateral extensor plantar without any meningeal signs. So to summarize, my patient, 32 years old gentleman with right hemiparesis initially and later progressed to involve the left hemiparesis also, with right facial weakness, with febrile encephalopathy, with raised ICP symptoms in the form of headache, nausea, vomiting. So with the risk factors of diabetes, COVID and steroids, with image suggestive of multifocal heterogeneous nodular and ring enhancing lesions. They are progressively increasing despite of broad spectrum coverage of treatment and that required decompressive hemicraniectomy. CSF was not much contributory. In the brain biopsy was also mentioning, which was done from outside, mentions that necrotic tissue with inflammation without any granuloma and hyphae, and negative for both aerobic and anaerobic and fungal and cultures and gene expert. So by that time he received ATT, broad spectrum antibiotics, antivirals, antifungals, a course of pulse steroids and IVIG, and decompressive hemicraniectomy was also done. So with this we considered the possibility of CNS infections at the first level, followed by CNS demyelination, followed by CNS neoplasms. At the first level we considered infections like bacterial, fungal, parasitic, even atypical free-living amoeba. So he was recently, prior to this symptoms, he was affected with COVID with steroid intake and newly diagnosed diabetes mellitus. So during the course of illness, he was in febrile encephalopathy with raised ICP symptoms and the image evidence of cortical subcortical lesions with nodular ring enhancement and lipid lactate peak. But the points against were he was not having fever in the initial 2 weeks of presentation and the baseline infectious workup was negative. So in the second level, we considered CNS demyelination is the possibility as he had the viral illness preceding to the onset of these symptoms. But the points against were the pattern of enhancement and the significant edema, and there is no response to the steroids which he received. The third level, we considered the neoplasm as the possible etiology, like glioblastoma multiforme or primary CNS lymphoma or metastasis, as he was having progressive neurological deficits and significant edema around the brain lesions. But the points against were he was having additional febrile episode and presence of the lipid lactate peak. So in this slide, I am showing the possible etiologies with progressive neurological deficits with nodular and ring enhancing lesions. So for the detailed workup, infectious followed by neoplasms followed by systemic inflammatory and demyelination. In the infectious, in the bacterial group, pyogenic abscess, tuberculoma, TB abscess, melioidosis, syphilis, listeria, nocardiosis. In the fungal group, mucormycosis, actinomycosis, aspergillosis, cryptococcosis. The parasitic group, NCC, neurocysticercosis, toxoplasmosis, amoebic, free-living amoeba. So neoplastic group in the metastasis, primary brain tumor and primary CNS lymphoma. So even though systemic inflammatory causes are so in the less common in this group, his findings. Sarcoidosis, neurobasets, Whipple's SLE, demyelinating etiology, MS, ADAM, tumefactive demyelination. So with the two evaluation of these etiological workup, we just looked into the other possible symptoms that points towards the etiology. Other than this COVID, steroid and diabetes mellitus with poorly controlled, He was not having any chronic cough, loss of appetite, loss of weight, no sinusitis, black nasal discharge, no skin lesions, no travel history, swimming or water recreational activities or contact lens use or any eye or ear complaints, no prior vaccination prior to these manifestations, no fever at the initial 2 weeks of presentations, no abdominal pain, chronic diarrhea, and no long-standing headache. So we sent for the detailed infectious workup along with the imaging of the brain with contrast. We also reviewed the slides which were done from the private hospital. So in the initial workup, we found only anemia with hemoglobin of 9 and the rest of the cell is normal. In the systemic workup, we found only mild hypoalbuminemia with normal RFT, LFT. So in the other workup with normal negative ANA profile and serum galactomannan was not raised, but all the inflammatory markers like ESR, CRP, IL-6, procalcitonin were raised. In the infectious work, the specific workup, CSF which was done from outside. So negative for the tuberculosis workup in the AFB gene expert liquid cultures, and the bacterial cultures were also negative in that. For the admissions, all the cultures, urine, blood, ET cultures are sterile, and cultures for amyloidosis are sterile, and the fungal workup, galactomannan, fungal stain, fungal cultures are negative. Even though toxoplasmosis IgG was positive, but IgM was negative, and the biopsy which was reviewed was also not showing any evidence of toxoplasmosis. And for free-living amoeba, we wanted CSF to be done, but we could not do with the fear of possible herniation as there is already increased mass effect. And for parasitic stool for routine microscopy as well as modified acid AFB stain are also negative. So viral markers are negative. Biopsies will be discussed in detail. HRCT imaging showed consolidation involving the apical and posterior segment of bilateral lower lobe, likely infective. 2D echo was normal, no evidence of infective endocarditis. Ultrasound abdomen was normal. CSF we could not do with fear of possible herniation. So with this, when the patient was admitted in February 2nd last year, so we continued antibiotics, ATT. We acyclovir completed for 14 days. Amphotericin B was added. Ceftriaxone was also added, but he developed Steven-Johnson syndrome on day 3, day 4 of its added, so because of which we supposed to discontinue. So our images was done on day 3. Images were discussed, and the slides reviewed from the outside are also discussed. After which we thought tuberculosis is the least likely possibility. Hence, we ATT discontinued. So as his sensorium continues to be not improving, we did his EEG, which showed the evidence of non-convulsive status epilepticus, which was managed with midazolam infusion along with anti-seizure medications. Sepsis, ventilatory associated pneumonia, bacteremia were managed according to the culture sensitivity reports. Nutrition and fluid balance was managed, and bedsore preventive measures were continued. And he had an episode of DVT which was managed with Clexane, and follow-up, so recanalization was also achieved. He had an episode of candidemia with Candida auris growth, so which was treated with caspofungin 50 mg per day for 30 days. So 1 month into his admissions, we noticed that there is a bulge, extracranial bulge at the decompressive hemicraniectomy site. So ultrasound gate aspiration of the pus was done and sent to the microbiology department, which will be discussed. On the 2nd month of admissions, the repeat MRI brain was showed the evidence of progression of the lesions. The 3rd month of admission, so with contrast imaging showed well-formed, well-organized abscess, which was surgical excision was done and sent to the histopathology. So now, so I will request a neuroradiology team followed by neuropathology team followed by microbiology team to discuss their counterparts. So first, I will invite Dr. Savishachi from neuroradiology department to discuss neuroradiology part.
Thank you. Good afternoon. I'll be discussing the neuroradiology part. The patient, the first scan patient had was in January, which showed ill-defined multiple T2-player hyperintense lesions in bilateral cerebral hemispheres. These lesions had foci of diffusion restriction and foci of blooming on susceptibility-weighted imaging. These lesions have both dot-like and small ring-enhancing lesions along the sulci and within the lesions. These lesions also showed a prominent lipid lactate peak on proton spectroscopy. Just a month later, there was extensive progression within the lesions, showing multiple T2-player heterogeneous lesions with central necrosis involving the left frontoparietal region, the left gangliothalamic region, extending through the corpus callosum into the right posterior inferior frontal region. These lesions had extensive diffusion restriction with sparing the central necrotic part and multiple foci of hemorrhages in the peripheral region. These lesions showed irregular nodular enhancement, and to note is that they showed hypoperfusion on ASL. Similarly, these lesions also showed prominent lipid lactate peak on proton spectroscopy. A month or two later in March, to April, there was extensive progression with well-formed abscesses showing ring enhancement and peripheral diffusion restriction. Based on this imaging, we could only think of infective as the possible etiology for this for the case, and the likely causes were as follows. These multiple ring enhancing lesions with the hypoperfusion on ASL favored the possibility of an abscess, but absence of a central predominant diffusion restriction, absence of a dual rim sign, that is outer hyperintense and inner hyperintense rim, and absence of the cytosolic amino acid peaks of acetate, succinate, and alanine on proton spectroscopy, and the absence of a hemorrhage disproved the possibility of a bacterial abscess. Similarly, absence of other tubercular stigmata and irregular wall enhancement along with hemorrhage disproved the possibility of a tubercular abscess. We had multiple reasons to think of a fungal abscess as a possibility of this lesion, mainly because of the multiple ring enhancing lesions, the irregular wall enhancement, no enhancement in the projections, hemorrhage, and the lipid lactate peak. However, we were confused when there was extensive diffusion restriction and hemorrhage that was disproportionate to lesion size. Another thing was that we did not have any Trehalose peak, which is not although very sensitive but very specific to a fungal lesion. The patient's immunocompromise made us also think of the toxoplasmosis as a possible cause. However, toxoplasmosis is known to cause a typical target sign of enhancement on post-contrast images, and also it is basal ganglia centric, which our imaging was not. Another possibility was of a free-living amoeba infection, mainly because of the irregular nodular enhancement, the hemorrhage. The basis of the lesion mainly on the gray matter white pattern junction, which is very typical of a GAE, the granulomatous amoebic encephalitis, and the rapid progression that the patient had despite treatment in 1 month. However, the primary amoebic meningoencephalitis usually has a basal purulent exudates with hemorrhage and necrosis throughout the vein, which are not seen here. Another possibility based on the early scans that we saw is a possibility of neuromelioidosis, mainly because of the ring enhancing small lesions that were seen along the sulci and the extension through the corpus callosum. However, neuromelioidosis is known to spread to the CNS through the cranial nerves, and there was no primary involvement of the cranial nerves, neither any brainstem, so a possibility of melioidosis was ruled out. I would like to invite the pathology team for further discussion.
Thank you, everyone. So the first review slides, which month of February, so labeled as tissue from the left parietal lobe. Here we can see that there was brain parenchyma extensively infiltrated by dense necrotizing inflammatory infiltrate, which was also present around the small and medium sized vessels. And some of the vessels show this infiltrating and damaging the vessel wall. Here we can see the extensive damaging of the vessel walls. The inflammatory infiltrate was composed of lymphocytes, neutrophils, plasma cells, macrophages. These are another vessels where we can see extensive damaging of the vessel walls and fibrin deposition. Some of the small vessels also show this fibrin thrombi, and there was extensive endothelial swelling seen in these vessels. In addition, there was extensive amoebic numerous amoebic trophozoites seen around the vessels and mixed with this inflammatory infiltrate. Here we can see the trophozoites. There's the central nucleus and this forming cytoplasm. Some of the macrophages also show this phagocytosis of the lymphocytes, RBC, and nuclear debris. Here we can also see this trophozoite. Here are some of the trophozoites seen and mixed with inflammatory infiltrate. The diagnosis of amoebic encephalitis was given at that time. This was a repeat debulking surgery, and that time we received the cyst wall. And here we can see that the cyst wall was composed of this fibrocollagenous tissue created by this dense inflammatory infiltrate, which was composed of this lymphocyte plasma cells. Here we can see the multinucleated Jan cells forming ill-formed granulomas. And there was extensive necrosis seen along with that. And among the necrotic material, here we can see the trophozoites. Here we can see the central clearing of nuclear clearing, along with the multiple disc trophozoites here can be seen. This is the past stain highlighting these trophozoites. Here we can see the trophozoite with central clear nucleus and this forming cytoplasm. And in few of the trophozoites, we can recognize this prominent nucleolus in the center. And the silver methanamine stain also highlighted this trophozoite. There was any fungal profile seen.
So overall, based on the diagnosis of meningitis, trophozoites, and granulomatous reaction, a final diagnosis of granulomatous amoebic encephalitis was given. The differential diagnosis of granulomatous amoebic encephalitis is either acanthamoeba or balamuthia. Naegleria was ruled out because it generally presents it neutrophilic meningoencephalitis rather than granulomatous reaction. The differential on morphology is different. It is difficult to differentiate morphologically because trophozoites are approximately of the similar size on HE sections. So culture studies or genetic studies can be done further to differentiate these. I would like to call Dr. Rosalind for microbiological findings.
Good afternoon, everyone. I am Dr. Rosalind Das from Microbiology Department. In February 2021, what we received pus aspirate from the scalp swelling of the patient. Okay, for free-living evaluation for free-living amoeba. As we know, free-living amoeba, basically, which are pathogenic to human body, are as per till present knowledge, there are three Acanthamoeba species: Naegleria fowleri and Balamuthia mandularia. Okay. And the patient is presenting with brain abscess. Acanthamoeba is known since most of its literature and reports says it presents as granulomatous amoebic encephalitis. Naegleria is mostly present as primary amoebic encephalitis. Balamuthia present as subacute amoebic encephalitis. And Acanthamoeba and Balamuthia more or less give same picture. Only thing is that the endemic zone, the geographical area where it is distributed, it is different. Balamuthia hardly reported from India, but Acanthamoeba is quite common in India, we can say. And Naegleria is presents as primary amoebic. It's very acute in presentation. Like 1 to 2 weeks, the patient will come to illness. So Naegleria, from the clinical picture, it was very less likely. We are left with this two ladies. What we received the pus aspirate. What we went for, we went for direct demonstration, that is the direct observation under microscopy. Then in vitro culture and molecular detection. Under direct demonstration, what all we did wet mount microscopy, that is just seeing under microscope, fluorescent microscopy, gomori-methamine silver staining, culture with non-nutrient agar plate culture, and molecular detection or confirmation by PCR assay followed by genomic sequencing. So in our direct demonstration, what we found at the low power field, we found well-defined structure, round well-defined structure, which are double layered, and this double layered on further fine focusing and further at a greater magnification, they have a folding inner membrane. Okay? They are non-motile, but they were having folded inner membrane. They were at this kind of picture can be due to macrophage, that is the host cell itself, or Cryptococcus yeast cell. Macrophages are more likely. Macrophage size was not matching with its size, and this inner folded membrane are very typical to a faster. Then, in Cryptococcus is likely very small and budding cell is not present. Then we did a fluorescent microscopy. In a fluorescent microscopy by chalcophore white stain it is done, and there we find a double walled cyst which flourished in this chalcophore white stain. Okay. So this kind of structure is very typical to Acanthamoeba, which is further confirmed by GMS staining, gomori-methamine stain, which gives a wrinkled paper appearance. And from this three microscopy, we are confirmed that 10 to 12 micron size well-defined round separate structure, which is quite suggestive of Acanthamoeba species. This is further confirmed by, since the clinical picture was very unusual, this was further confirmed by PCR assay. In the PCR assay, we have amplified the ribosomal RNA, and 180 base pair segment of the Acanthamoeba was magnified, and this was further sequenced. Genomic sequence was outsourced, the sample was outsourced and genomic sequence was done, and genomic sequence again confirmed it to be the Acanthamoeba species. Okay. So, yeah.
So As we have made a final diagnosis confirmed with the initial histopathology reviews followed with granulomatous amoebic encephalitis. So we worked up for the immunodeficiency workup, which revealed only reduced CD4 count and reduced neutrophilic oxidative index, and rest of the B, T, NK cell markers are normal with normal immunoglobulin levels. So, and the source evaluation, sinuses, eyes, skin, systemic examination was nothing revealed, nothing revealed. So, on with the diagnosis of GAE, along with amphotericin B, we considered the 5 drug regimens: fluconazole, ceftriaxone, albendazole, azithromycin, rifampicin. Ceftriaxone supposed to be discontinued because of Stevens-Johnson's. Amphotericin, after giving the cumulative dose of 5,950 mg, so we discontinued. After discontinuing ceftriaxone, so we added flucytosine on day 15. After discontinuing amphotericin on day 38, we started miltefosine. So he also required surgical debulking after the well-formed organizations at 10 weeks after the admission. So now I'll discuss special mentions points about this specific drug by infectious disease department.
Thank you, Dr. Govinda. So regarding the treatment part, the main challenge was that there is no standardized guidelines or any RCT evidence to guide the treatment of acanthamoeba. Basically, we have to sort out from the case series and case reports that have been published with successful treatment. And these were the agents that acted specific targets for the options that we had. So few drugs, most important of them being miltefosine. It acts on the cell membrane and disrupts it. The amibicidal concentration was 16 microgram. That is easily achieved with the usually advised doses of 50 mg TDS of UID. This was a comparison of non-keratitis acanthamoeba infections where the survival was higher with those who received. Amphotericin B, although used, it doesn't usually achieve the amoeba static concentration, which is with the usually clinically administered doses. And it doesn't have amoebicidal or cysticidal activity. Plus, it shows a phenomenon called natural resilience. It is not acquiring resistance, but when you keep exposed to amphotericin B, the MICs keep increasing, tenfold higher with every passing day. So we have to choose a multi-drug regimen for this patient. And these were the other anti-amoebic agents that were used previously published in the literature. So it is important that we have a cysticidal activity as well, because if the cyst persists in the parenchyma, it can lead to relapse later on. So the azoles, which have both proficidal and cysticidal activity, although at a much higher concentration, and they achieve the usually acquired, achieve the concentration in the usually administered doses. Trimethoprim, sulfamethoxazole, 5-fluorocytosine, albendazole, azithromycin were other agents, although effective agents, although they do not show cysticidal activity. Again, an issue with 5-fluorocytosine is that it shows resilience similar to liposomal amphotericin, and rifampicin, it doesn't achieve the proficidal concentration with the usually administered doses. Caspofungin, again, the cysticidal activity is not seen at the usually administered doses. The second issue was whether the drug reaches the target site. So miltefosine, which is strongly recommended by CDC, we see that the published literature, the sparse literature, shows very poor penetration to CSF, but the parenchyma.
So sorry to cut you down because we are cutting down the time, so we need. And the take-home messages Dr. Anu will give. Thing is that this patient is one alive, off ventilator, discharged home, come back, be alert, only has right hemiparesis, get a cranioplasty done, got twice operated, he's talking, is in fact communicating, he's there. So the family is overjoyed, and then we have actually seen that there are very few cases of amoebic encephalitis who have actually survived in the world literature. So, and this is post-COVID. So this was an achievement, and we couldn't have done this without the absolute support of ID. Was like a rock hard support with us and all the ancillary departments. And so, sorry, Anu, just give the take home message.
Amoebic
Next time we'll take some questions.
So amoebic encephalitis should be considered in any patient who presents with rapidly progressive brain lesions. Fever may not be present as the initial symptom. COVID should again be considered as one of the predisposing factors in today's era. And early and effective treatment regimens with abscess drainage may be the game changer, and miltefosine appears to be a promising drug in such patients. So our special thanks to all the teams, Dr. Gaikwad and his team from Neurology, Dr. Manmohan Singh for his skillful surgical intervention, Dr. Vig and Dr. Manish from ID, Dr. MC Sharma from Pathology, and Dr. B.R. Mirdha and his team from Microbiology. So thank you. Any questions?
Online, do we get questions online? Then we can always communicate. If there are questions, just post it, then we can. Yeah, right. Yeah, so the source we had actually gone into the detail about. There's one source which I have specifically wanted is after post-COVID, a lot of people do this nasal, like, it's like an oleation or something. They put water into the one nostril, take out from the other nostril. This was in practice, especially during the COVID times. But we asked, and they said no. But he never swam. He wasn't even exposed to any woodwork or any other, gardening or anything. He was just a simple man, home isolation, got back to work, and was driving home from work. So we don't know. But then this has happened even repeatedly. We had a Balmutia in a dental student who never swam in his life. So therefore, I think these do come. It is essentially something which probably entirely um, offsets the immune system, and COVID was one such thing. And post-COVID amoebic encephalitis has been described in 4 patients in the US. They did not publish because all 4 died. So there has been these stray reports, and this one this was of course a success story, but probably very, very. From what we had seen, there were 148 cases. And probably now with these cases added on, maybe those 4 cases, they never got published. But that's an interesting question because it is true with this kind of immunity, I guess we would be seeing more of such. Probably if someone, I mean, then these do come as rare. And Bal Mutia we had discussed, but that case died. Um, her CPC in IN was something different, but it's possible, but that itself is more than 15 years. Correct. That the free living amoeba hanging drop preparation in all the very acute presentations of them, that's a routine practice. But again, as Professor Gaikwad said, it is rare, but probably if someone keeps a watch now with the altered immunity in the universe as such, probably we should be able to see some change. We should, yeah, should. But this imaging was ghastly. I mean, it was astronomically, it was like a holocaust in the brain. And all of you would agree with me. From things like that to someone who's alive and communicative and be there in the family was something. And thanks to Dr. Manu, who had the guts to go ahead and do it again. This was a second surgery. So I think for want of time, we'll close it.